Ready, Lance?
Let's do it.
All righty, perfect. Hi. Hello, everyone. Welcome to our webinar. My name is Mike McWilliams. I am the Chief Revenue Officer for Reliable IT. It's my pleasure to introduce to you Lance Godsworth. Lance and I have worked together for about 10 years now. He was a client of mine for many years and then has joined Reliable as our CXO and helping our clients all over the place. He has over 20 years of experience in the C-suite with large practices, and he's been the MC for us for many years at our Reliable IT Healthcare event. Lance, I know you'll do a great job, and I'm going to hand it over to you, and I'll be taking, again, there's questions that you can submit to the panel, and I'll be filtering those to Lance. Lance, take it over.
All right. Thanks, Mike. Hello and welcome to the Emergency Survival Guide, Protecting Your Healthcare Practice and Revenue in 2020 webinar. My name is Lance Godsworth and I'll be your MC today. We're glad to have you here and know that your time spent with us will be well worth it. We have a fantastic panel of speakers lined up covering a variety of backgrounds. We expect each of you to walk away from this webinar with more insight on how you can both protect and build your company during this crisis. Please note, we'll be taking questions from the audience throughout the webinar. If you have questions for the panel, please submit them via the question box that's on the right-hand side of your screen, and we'll do our best to put them in front of the panel on your behalf. Please let me start by thanking the following leaders for their willingness to participate in this forum during a very busy and stressful time. Their participation is a testament to their shared goals of improving the world of healthcare. Our shared goal for today is to learn what technology solutions these leaders have implemented and or capitalized on to not only survive, but to thrive during the crisis. While it's crucial for our healthcare leaders to act, preserve, and protect practice assets in 2020, it's also crucial that we look for opportunities to grow during this crisis. Ultimately, our goal is to get through the short-term crisis, minimize loss, and come out on the back end of the situation set up to both catch up and move past historical performance. For these reasons, we're interrupting the normal course of your day to provide you with a special edition of this Emergency Survival Guide program. Our first two panelists will be Mike McCaslin and Karen Clark from Somerset CPAs. Mike will be kicking things off with a brief State of the Union, where he'll speak to the current and future state of healthcare in this new paradigm. Mike provides services for healthcare clients throughout the country. As a principal in this group, he has many areas of expertise, which include the development of healthcare delivery systems and multi-physician specialty organizations, and the negotiation of physician and hospital relationships. Mike also specializes in joint venture and merger analysis, transactions, strategic planning, buy-in and buy-out, structuring, and restructuring, development of governance, and succession planning. Mike speaks regularly on healthcare, accounting, and practice management issues to physicians, hospitals, and other medical organizations. Our next panelist is Karen Clark. Karen has spent the last 20 years as a healthcare CIO and now provides independent technology consulting to organizations, helping them align technology with their strategic goals. Prior to beginning her career at Somerset, Karen was the CIO for Ortho Tennessee. She currently serves on HIMSS National Nominating Committee as a healthcare sector chief for the FBI InfraGard Alliance and as a member of the Data Analytics and Benchmarking Council for AAOE. She speaks nationally on the topics of healthcare payment and reform and cybersecurity and is passionate about transforming the use of health IT to better serve patients and providers. Our third panelist, Chris Francis from Panorama Orthopedics and Spine, was unfortunately called away urgently to deal with the reopening of Panorama's facilities. He may or may not be able to make it later during our meeting. Our fourth panelist is Matt Fletcher from Illinois Bone and Joint. Matt serves as the Director of Systems Integration and Development for IBJI. His primary focus is creating a modern, efficient operational platform through strategic decision-making, process improvement, and creative design development. He is passionate about technology and the impact it can have on the way IBJI delivers care to patients. Matt joined IBJI in 2006 after graduating from Purdue. He's a motivated and experienced leader with a high level of project management and strategic planning experience. Our fifth and final panelist is Ty Allen from Social Climb. Social Climb is Ty's fourth successful business in marketing and technology space. He is passionate about building systems that actually grow practices and improve patient experiences. Social Climb enables thousands of physicians to automatically attract new patients to their practices by building their online social reputations and automatically targeting ideal new patients. Delivering nearly 1 million patient-customer interactions every month, Social Climb helps practices transform themselves inside and out. Okay, enough for me and enough for the introductions. Let's get started. Mike, why don't you kick us off with your State of the Union address?
Sure. Thanks, Lance, and good morning or good afternoon, wherever you may be at this time. What I want to do is take us through what I'm going to define as maybe 6 phases of kind of where we've been and where we're going, and try to create the thought process that while we've been in crisis, there's probably a tremendous amount of things that we've learned that need to be permanent applications going forward. And when we get out of the crisis mode, you'll be able to better think that way, but we ought to kind of have our notepad to the side where you've all day, every day been thinking about, wow, we're doing this now. We didn't think about it. We were forced to, but is it something that we should look at as a permanent solution going forward? As we look back at the phases, well, the first phase was absolute craziness, right? We were forced, without understanding the government programs that were going to be in place and the speed at which things were shut down, to deal with overhead, what I'm going to call the overhead management scramble. I had staffing issues, furloughs, layoffs, terminations. And now somewhere in time, you're going to look at, so how many of those people do I miss or not miss? And maybe we didn't always keep the best. I had rent deferrals. So I'm looking to my landlord. That may be my own building, or it may be an independent landlord looking for deferrals and having that rent tacked onto the back end. I've looked at all of my vendors and suggested and asked that they would defer payments, delay them, push them out until we recovered. I looked at my malpractice and looked at ways to reduce that because we have reduced volume, but all items sitting there saying that, I don't have the same business. Now, on the plus side, unlike other industries that have a permanent loss, there is some expectation that there will be a boomerang on these elective cases, all subject to those people still having jobs, still being covered by insurance. So we had the initial overhead scramble mode. The next mode was, man, I need to really get with my bank. I need to expand my line of credit. I may need to defer some existing loan payments, and I'm going to get a real test of my banking relationship. And that's really going to be tested in the next phase, which became the CARES Act and all the SBA loan work that most of you were doing for those that qualify. And you got a real test of your banking relationship in terms of how helpful they were or how helpful they were not. And you may look at your line of credit process, your loan deferral process, your SBA loan application process and say, wow, I have a great banker who's a partner, or I have a commodity and I need a partner as a banker when I get out of this crisis. The CARES Act has created a tremendous amount of work, conversation, and we still live in a fair amount of unknown, because what happens is obviously the people in Washington have to pass an emergency act that has a lot of high-level rules without a lot of detail. So every day we continue to look for updates and clarification. It's a moving target because we're operating on items that we think are possibly going to change. We had 3 sources of money that came out of Washington, D.C. that have all potentially been beneficial. Some groups have chosen to participate in all, some have not. We obviously had the Medicare advance payment. We had the SBA 7A loan under the CARES Act, which is now also known as the Payroll Protection Program. And then we have the surprise money that showed up on April 10th for most people in their bank account, the HHS/Medicare grant money, which technically, or at least the intent is that won't be repaid. There's still some concerns about attestation and the coronavirus patients that you're treating. Clearly, most practices who do elective work have had a significant drop in revenue. And so the expectation is that ultimately that will all not have to be repaid. So I got through those first three phases, a lot of scramble, and now I'm still in what I'm going to call phase 4 is now I have this money. I'm going to have the issues of how do I manage it, how do I allocate it, and who wants to make a claim. So my PPP loan, obviously there are a lot of provisions you're all working through on how to optimize forgiveness with the best business model, understanding I may not be ramping up. So how do I balance paying everybody to do nothing for 100% loan forgiveness and then not having any money when I've paid everybody and now we start ramping up? One of the challenges I think everybody has is, and if we really got outside of this pandemic, we would say, I've got a 1% interest loan payable over 2 years. And as I said on a couple of calls I've been on today, if we didn't have any of this and somebody showed up on your doorstep and offered you a couple $1 million at 1% interest to be repaid over 2 years, without all of this, you'd say, give me all that money you have, right? So I think we got to be careful of getting too hung up on the loan forgiveness piece and not focused on what's a rational business decision to bring people back in an appropriate fashion. And you're managing that against a lot of staff that are probably pretty happy on unemployment with the federal government's contribution to that, making as much money as they would and not working. Now, maybe not a great habit, but anyway, then I've got Medicare advance payments and I've got the grant money that's sitting there. And those are both based upon historical Medicare volume. So now am I managing my doctors who are making a claim for that revenue being dropped in their particular bucket? Or am I going to set at least the grant money aside and say, we'll just set it up as a separate P&L, post all of our expenses against it, and it'll benefit everybody in the way that the overhead's being paid. Real key there is you're managing is that you can't use your grant money for the same resources that you're using your payroll protection program money, so you've got some management issues there. The fifth phase, which is people are starting to begin to think about, and Lance, you mentioned that with what's happened with Panorama right now, because in Colorado and state by state, you're going to start seeing people lift some restrictions. On the healthcare community side, we're going to see that gradual lifting on elective procedures, probably favoring the hospitals today before our surgery centers and our private practices are able to ramp up. But now we're trying to look at how does social distancing come into play? How does testing of every patient and every employee come into play? I give credit to Karen Simonson on one call, and she said, you really have to treat this like the AIDS problem that we had in the past, and you have to assume everybody has it, because on a given day, one test a day does not mean tomorrow that you're safe. So we have timing, scheduling, ramping up, cash flow management of all that. Hopefully you're managing the three different the sources of funds that came in before you have to tap into your own line of credit. And then the last phase, before I turn it over to the rest of the panelists, is I'm calling the dust settles, now permanent changes that come out of this, right? Telemedicine. It was forced on everybody. We had huge crashes of systems at the beginning of the process because everybody went to telemedicine at once. Where does telemedicine have a long-term play, both in your current clinic operation, but in outreach operations? Telemedicine may save in brick and mortar investments, which is the second highest expense item. Technology, and I'm the least, you guys are the technology experts, but technology is going to come into huge play because as we've watched, hopefully, our staff be reasonably productive at home, or certainly not in $27 and $30 a square foot space, where does technology play for moving that into a lower cost structure? Real estate, how much real estate do I need going forward? Or am I going to be looking at repurposing from overhead utilized space into revenue generating space to grow my capacity to see patients? I think outreach will be structured differently. I think we've all probably gotten a lesson on our physician employment contracts related to employed physicians and how those might be structured to create a better safety net for practices. Again, I know you plan on these once every 70 years, events like this. Your surgery center, I think even before this with the transition to outpatient care, we would have said the surgery center is going to be the best asset you ever have in the next 5 to 10 years. I think we're going to have a huge fear factor of patients walking into hospitals where COVID has been being treated, and unfortunately for those hospitals, there'll be a little stigma there. I think there'll be more interest in a facility such as your ASC that hasn't seen COVID patients that may be viewed right or wrong as being a safer facility. And then the only negative side out of all this, unfortunately, on the physician world is that there was good movement headed towards leveling the playing field between hospitals and hospital-employed physicians and neutral site payment issues and then some other things. And I think, unfortunately, we'll probably see hospital systems jump on this particular pandemic and the incredible cost associated with it and the negative economic consequences to defer or fight back against any ongoing transitions to outpatient or reimbursement differentials. So unfortunately, I think we'll see some of that stalled where we were making good progress. So again, I think every day take something from the crisis that you would write on a notepad and said, we need to look at that as some type of potential permanent solution that benefits us all down the road. And I think that'll be a good way to look at going forward. So thanks for your time, and I'll stop there and turn it over.
Perfect. Thank you, Mike. That was very insightful and a great summary to get our conversation started. Now let's open the panel discussion with a few questions. There was one follow-up to a point you made during your opening, Mike, that I want to bring up to the table first, or the panel first. Is anyone planning on using the Medicare prepayment funds during the first 121 days after receipt? And if so, how do they plan to account for it once Medicare starts its offset? Mike, do you want to start us off with a response to that?
I will. Karen might have a better response. I think what I've seen is people setting their separate buckets of money in different accounts to figure out how to account for those. And I think people may use the Medicare advance payment as the fund of last resort, because if in fact you don't have to use that, when Medicare comes back to recoup the funds, then you'll simply, as a claim is processed with Medicare and they withhold or recoup, you will take from that bank account and drop it into that doc's column, so to speak, in the income distribution formula. I think if you end up spending that money, you're just going to have to be able to figure out where I'm going to bring or how I'm going to reduce and account for the reduced payment once it's recouped. So my best answer is don't spend it if you're going to. So that may not be a direct answer. And Karen probably has a better solution on those that actually spend it.
So a bit of a war chest approach is kind of what you're suggesting. Karen, what would you add to that?
Yes.
Those on the call that aren't in the guts of payment processing, Medicare uses codes to identify why claims are paid or not paid, or when payment is withheld. We haven't found yet which exact code they're going to use for this Medicare Advanced Payment Program in this, but there will be a code that identifies if that money is recouped. But I really agree with Mike that if you can, to hold that money in reserve as those claims are going forward aren't paid and that's recouped, then you put that in the doctor's bucket as you go. Otherwise, I think it's going to be very, very difficult to, the accounting of it's going to be very, very time consuming, labor intensive.
Very good, very good. Matt, this next question is for you. What should my short-term telemedicine approach look like? What areas should I focus on?
Sure. Thanks, Lance. So at least in the case of our practice, what we focused on, given the situation where what was, telemedicine was basically something that people were looking at as an option, became a mandatory way to still see your patients. So when you're scaling that up quickly, you have to kind of throw all of the nuances and all the little bumps in the road that maybe you would take as a planned project and kind of throw those aside and say, what's the essential piece of telemedicine that we need to do? And for us at Illinois Bone and Joint, it was basically, how do we connect our providers and our patients? How do you keep that as simple as possible? We have a lot of different patient demographics, as I'm sure everybody else does. And so you want your solution to scale from a younger patient who's pretty tech savvy and is more comfortable with this type of environment, all the way up to an older patient who maybe has never done this before, or has somebody to help them, and that it scales well to that group of patients. So we very much focused on how few clicks can it take for a patient to actually see their provider in front of them. how easy is it to offload any IT concerns away from the provider and away from the patient? So if you can make it as seamless as possible, we found that to be the most important part of scaling up quickly. All the bells and whistles that you can add to it are great, but if you can't get the patient to connect with your provider, none of those will mean anything. So that's really where we started. Karen?
Karen, you have an addition?
I think one thing that's really interesting is all of these folks that we were all worried about wouldn't be able to manage the technology, typically our older patients. Now they've all become Zoom experts, and they've joined their family happy hour and all the Zoom meetings with all their children and grandchildren. So I think the technical competency of the group has gotten a huge boost in the last 6 to 8 weeks, wouldn't you say?
Most definitely. I think we've underestimated these folks. That's for sure. We've underestimated. Let's stay on the telemedicine theme for a question or two. I've gotten a couple more questions in. Matt, let's start with you again. How do you plan, how would you see the future of telemedicine? How do you see it? Do you see it, is it going to stay? The conversation I have heard is, hey, it's going to be hard to get that toothpaste back in the tube. Give us your perspective on that, and then I'll give a few others the chance to speak on that as well.
Yeah, absolutely. I think both, especially the patients, it's going to be hard to, especially in rural areas, expect them to drive in for a follow-up visit, for example, when they've lived in a world where they can do that right from the convenience of their home. And I think providers, to a large degree, who were maybe a little bit more pessimistic about it, will have seen the opportunities and will be looking for ways for their business to grow or to sustain or you know, just grow the practice in different ways than they would have. So we definitely see this sticking around. I think you know, kind of the big question is what is going to happen with you know, the policies and the payers after this pandemic is over, and what does that look like? So we'll have to keep our eye on that. But I think for us, we're still planning this to be a long-term tool that we use and that we continue to expand on. And so we're going to work our way backwards from what are the essentials to how do we make this a you know, a long-term part of our planning.
Very good. Thanks, Matt. Mike, you had something to add?
Yeah, I just think if we had our patient-centered care hat on, which you'll remember I talked about at your fall conference, then we would look at it and say, well, what's in the best interest of the patient? They don't have to get in the car. They don't have to come into your waiting room. They don't have to have all that social interaction, which is going to, I mean, we can open up tomorrow, right? Our patient's going to show up. They're going to want to know and it's going to be a while, especially for probably elderly and or those with some type of risk condition to get comfortable sitting there next to people. So if we're really focused on patients, we'll say if this what works best for a patient, they avoid an hour round trip or any of that, you'd say then we should be focused on serving the patient and making policies and rules in DC that best serve the patient. And you know, there's a cost to that. I got to spend gas money. I got to do this. I may have to park, all these other things. We're making life better for the patient with telemedicine. Obviously not all visits, you know, can be that way, but so many follow-up visits, and I'll go back especially to outreach patients where you provided services in a patient that's an hour and a half away. Okay, why on earth do we want them to have to drive in? So I can't see anyone that's focused on patient-centered care objecting and not making this permanent solution.
Very good. Great comment. Ty, yeah, I was actually just about to give you the floor, Ty. I know that you're engaged with a large number of practices. You're very focused on customer experience. Why don't you add some comments to the telemedicine conversation?
Thanks, Lance. We've seen a lot of practices take advantage of a couple of things as telemedicine has become part of their repertoire. One of those is Google 2 weeks ago, a week and a half ago, introduced COVID-19 links and telemedicine links on Google My Business pages. So a lot of the Google My Business pages for your doctors and your locations have kind of been on hold. Google, a couple weeks ago, kind of released a few of those features, including a special link that causes your presence to rank higher if you actually have a telemedicine link in your message, in your presence. So Whatever that means, Google's deemed it to be valuable, and therefore, when somebody does a search, you're going to get seen more if you're embracing that telemedicine link. The second thing that we've seen practices do beyond just getting those links set up correctly on all their pages is making proactive outreach to their patients to let them know that telemedicine options are available. It's one thing to deal with those that you're trying to handle who are already on your schedule or need follow-up, but we've seen some practices get really innovative, reach out via text message to some of their patients, informing them, hey, if you do have an issue, we have a telemedicine option for you. We also have, some cases, they've got urgent care facilities open so that patients don't feel like they're stuck during this time. They have a telemedicine option maybe first, and secondly, they can see a doc in an urgent care setting if needed, which is something that some groups have actually turned back on in some cases.
Very good. Excellent. Ty, let's stay with you for a second and address another question. From a marketing perspective, what should a specialty group be doing during this crisis, if anything?
Yeah, so I hit on a couple of those things, but the main thing I would say is take advantage of the opportunity to get your listings and your presence outside of your website as solid as possible. Two of those things, I hit on them already, are get your link set up correctly to your telemedicine options on all of your listings. Google has it. I expect some of the other listings, I expect possibly Healthgrades to introduce a component on this and some of the other listing services to make it very easy for a patient to connect and schedule, not only schedule for appointments, but schedule telemedicine specifically. And then, secondly would just be stay connected with your patients. There's potential for leakage, right? Everybody's sitting there going, well, we got this backlog of patients that are stacking up. They need care. We fear, I hear this from lots of practices, we fear that we're not going to be able to get to them fast enough. We're going to be working on Saturdays and Sundays. We're not going to be able to get to them fast enough. How do I keep those from going off to other groups who may be courting my patients? The best thing you can do is stay in contact with them. Message them via email, via text, so that you can stay in their minds, know that they're progressing towards care in your facilities and with your doctors.
Very good. Excellent. I appreciate that. All right. So the next question is going to shift gears just a little bit, and this one is for you, Karen. Karen, we had to move a good number of our staff home to work in a hurry. What should I look at to be sure I'm not more vulnerable to hackers?
Well, I think there are really two things to look at, the immediate need and then sort of the more long-term need. Immediately, it's important to understand that expert hackers don't hack systems, they hack people. And a business email compromise is the number one way you're going to get hit. There were over 2,000 COVID-related web domains registered just last month. And these guys know this and they're using it to their advantage. Our users were always our most vulnerable folks in our security chain, even when they were behind our secure corporate firewall. And now that some of them are at home, you've pushed out that attack surface to every employee's home. So I would say immediately make sure that your employees are connecting using VPN software. That's number one. And number two, make sure that you have two-factor authentication turned on, not only on your VPN, but on your email application. It's free or very inexpensive. Duo is $3 or $6 a month per user. Google Authenticator is free. Authy is, I think, $4 a user. So it's not expensive. It's easy to do. And it's the number one thing you should do immediately to make sure that you haven't opened up a giant hole in your security posture.
Excellent. I like it. Matt, did you want to add anything about what IBEJI is doing to secure their at-home workforce?
Yeah, so in addition to what Karen mentioned, what we really try to do is create a lot of, we actually use a lot of cloud-based products that aren't connecting back to a centralized server. Again, we use multi-factor authentication on our communication platforms and on any system, any critical system that has PHI in it. So we really try to decentralize our communications and not have too much information all flowing back into our corporate file servers and things like that. So I think just making sure staff are educated, to Karen's point, education end user training is the best way to make sure that phishing attempts and things like that don't actually land. And so just drawing attention to it. As Karen mentioned, there's a lot of increased COVID. It's kind of sad, but there's an opportunity for hackers to actually target people who are concerned and they're looking for answers from official chains of communication. And so we've seen a big increase in that, where it looks like it's coming from the WHO or from the CDC. And so you really just need to train your staff and create awareness that they can look for that.
Excellent. I appreciate that. So, Mike, what have you seen? What kind of security measures have you implemented for your at-home workforce?
You asking this, Mike? I would defer that to Karen, our technology team, as I probably am the least technology driven on that. So I know everything Karen mentioned, I think we're doing more than likely. And we're going through the same thought process of, gosh, we got all these people working effectively from home, communicating using Zoom or Microsoft Teams. How might that work going forward? But Karen, you can probably talk better to some of the security things that we have, especially as a financial services firm.
Yeah, well, of course, we always had to have a lot of security in place as a financial services firm, and I'd certainly like to echo heartily everything Matt said. I have two things. Number one, I would say employee education can be difficult because all of our folks, us included, are bombarded all day long with these messages about hackers and how it's dangerous. And I think if you're not careful, it can become noise. So what I've found is, if anyone here on the call has either a personal experience where your company almost wire transferred $10,000, or someone you know has been hacked, or someone else's, there's been an attempt against their bank account, when you can relate a personal, real experience to your employees, it just resonates a lot more when you can say, this happened to me, or this happened to Susan down the hall. I think that really helps. I think the other thing for folks to think about in this call is, although these things are good immediately, as we're talking about enhanced telemedicine, perhaps allowing more of a remote workforce, perhaps there's going to be a second wave of this virus. It calls our attention to the fact that building out a robust and secure remote infrastructure is key to being able to support whatever we need to do going forward. And so the time to do that is now. We've now learned what's worked, what hasn't worked, what we need to do, and now the time to do that so that we're ready for whatever comes next.
Very good. Very good. All right. So one more email from the audience on this subject matter. Groups are seeing a huge influx of phishing emails. What do you recommend users do so they don't click on those links? Let me start. I know that a number of our clients have asked that question, and we have programs that we recommend that automate this training so that you're not put in a position where you're already extremely busy, where you're having to create those educational platforms. They exist. They're things that you can just roll out. So that's one of those scenarios where it would be my suggestion to reach out to somebody like us and have you help them. Matt, would you like to talk about what specific type of program, maybe without a name brand, what you've rolled out and what sort of methodologies you've employed?
Yeah, definitely. So before you get to the point where the phishing emails have landed in the inbox and you have training to your users, I would say one of my biggest points of advice would be to get an email platform and to make smart decisions about how you deploy your email platform to avoid multiple points of failure, right? So for Illinois Bone and Joint, we've chosen to use Google as our email provider. And so Google at the server level is actually doing, I read a story that they're blocking a lot of the COVID-19 phishing attempts because they're monitoring for it. They're a part of the solution with you. It's not all up to your IT department. So as much as I'd like to take credit for some of that stuff, a lot of it happens before it even gets in. And then once it does get in, then you just have to really make sure that, again, you've done the basics. Just one single end user training can take your risk from like a 30% risk down to a single digit risk if you just cover the basics. And again, you need to make it, I hate to use this analogy, but it's kind of like YouTube. You want it to be 2 to 3 minutes, 4 to 5 minutes, something that staff will actually watch. If you try to do it and make it into at least in my experience, if you try to make it a comprehensive 45-minute course, they're not gonna absorb what matters, which is here are the things to look for, and here's what to do if you do suspect that you've been involved in any kind of phishing. Because awareness of the actual attack is just as important as prevention. You want to jump on these things quick if something does happen. So,
Karen, go ahead.
There are several products on the market. Again, we won't mention names, but that do something called link inspection. So when the email does get to your user, that link has already been inspected and checked for safety. And I think the best thing, to Matt's point, is to prevent that thing from even hitting the user's inbox, because especially now with people at home, the dog is barking and the kids need lunch and everything else is going on, and people are skimming their email and they're just clicking to get through their day. And I think really the key is to prevent those things even getting to the user in the first place. Google does a great job with their filtering. There's link inspection, and there's a lot of stuff you can do at the perimeter that even if that link is clicked, if any anomalous traffic tries to phone home, that traffic is stopped at the perimeter. And that gets pretty technical, but at Ortho Tennessee, we had over 800 people. You can't have 800 security officers. I mean, people are just trying to do their job. And so I think the key is to put guardrails in place so that it's really, really hard to make that mistake instead of easy.
Yeah, Matt, go ahead.
And just to add on, I think this is where some of the question was going as well. As you mentioned, Lance, there are systems out there that if you want, besides making the content easy to absorb for your staff, it can actually provide you risk scores for your staff in terms of if somebody seems to be failing to identify phishing repeatedly, you can do advanced training. So there are options out there for that. And if that gives your either IT or your leadership a sense of comfort with how your staff are prepared, there are options like that out there as well.
One of the other things that we are recommending, especially for leadership, people in key positions, is two-factor authentication. I know that you've probably implemented that at IBJI. Can you speak to that? Maybe Karen as well, and follow up to Matt.
Yeah, so we definitely have implemented two-factor or multi-factor authentication. As Karen mentioned earlier, there's a lot of different platforms out there that can be extremely cost-effective, free, or just not that much money, depending on the size of your organization. The next step for us in terms of that is you can do that on each of your platforms, and that's a great first step. And really, for most groups nowadays, if you don't have that, it's almost a misstep. You need to make sure you're doing that. But then you can look at things like Duo or Imprivato, different systems that allow you to create a single sign-on for your environments that's high security and highly monitored, so that staff have that ease of use that you want to try to give your providers and your staff, and you also have that peace of mind. So we're kind of on our road to that endpoint that we want to get to.
Great. Karen, do you want to add anything to that?
No, I agree with everything Matt said. We got the same kind of pushback. It's too much of a hassle. There are too many different passwords to remember. And so those solutions like Duo, where it's the same authentication method, whether I'm logging into my email or I'm logging into the company VPN, and it actually pushes the request to my phone. So all I have to do is hit the green check mark. That was a big help for us, for people getting over that resistance to the hassle factor. But it's the number one thing you can do to increase your security by a factor of, I don't know, Matt, 10, 100. It works.
Very good. Very good. All right, I'm going to shift gears again for another question from the audience. This is one of those things where we've all explored working from home now, and we've gotten accustomed to it. And I think we realized, wow, we're pretty good at this. So Karen, why don't you start us off with this question? If after COVID, I decide to move my back office or some of my people that don't require MOB space, if you will, if I want to move them home or to less expensive real estate, what should I be considering? What moves should I be considering from a technology perspective?
Well, let me start first with a non-technology perspective, which is, now that we've had a lot of people moving home, a lot of people found it's not all it's cracked up to be. And you may find some people say, you know what, it was hard to work at home. It's distracting. It's very difficult. There's a great article was published by MIT on the collaborative benefits of keeping people together in an office space. All those mini affirmations we get as we walk past the hallway. Hey, how was your weekend? I like your jacket, whatever. Those mini affirmations really do build teamwork and cohesiveness. So I think people, just from an operational and human resources, I think carefully about putting everybody home. So from that point of view. Number two, if you're going to say, okay, we're going to have remote people in whatever remote, situation we're going to have them in, there's just a couple of things. Number one, you've got to beef up your remote security. You've got to make sure your VPN is rock solid. You're using multi-factor. Number two, you cannot allow personal devices. You've got to use a corporate owned, managed, controlled laptop. Number three, I would look carefully at some sort of virtual desktop environment so that even when people are connecting in remotely, you've got complete control over what they can and can't do, and your company data isn't leaving your company network. And I would look carefully about having some good policies and procedures. When people are home, sometimes they can save company documents to a local drive. So you start to lose control over your company information. I'd make sure you're using something like Windows Sync so that you're syncing all that information back to your company. And you've got some pretty good procedures every evening about leaving laptops on so your IT team can push out patches, push out updates, run Windows Sync, force a reboot, all that kind of stuff, so that when your remote user comes in the next morning, that laptop is up to date, safe, backed up, in good shape. I hope disk encryption goes without saying. Of course, that should be on. And then that sort of thing, if the laptop is stolen, if the child pours a cup of coffee on it, again, whatever happens to it, you've lost the laptop, but none of your company data. So I would say data governance and safety and backup would be one of my number one concerns in that scenario.
I love it. Matt, why don't you jump in and tag on to from what IBJI is doing?
Yeah, I'd say it's similar to the kind of the outline that Karen just provided. We also are trying to, as I mentioned before, not put a lot of consistent barriers in the way of staff getting to what they need to work. So I think in addition to staff being able to work from home, they need to be efficient at home. You still need them to be able to do their job without jumping through a lot of hoops. So it's that balance of security and the efficiency of your staff. You can't go just at the computers. You have to think about phones and telecom, and how do you do that remotely? I know we recently moved to an integrated phone system that has the ability to have your work phone patch through to your smartphone, for example, and to make inbound and outbound calling. So there's a lot of considerations that a practice needs to make of how do you stay in contact, to Ty's point earlier, how do you stay in contact with your patients? How does it look and feel like it's the business, not an individual at home doing their work? And how do you make sure that that communication is all, again, abiding by your policies and procedures and making sure that it stays within the organization? So that's a big challenge as well, and something that we've had to work through over the last few weeks. So
very good, very good. Another question from the floor. This one is specifically for you, Matt. It says, Matt talked about cloud solutions. Does the panel think that ortho groups should move to the cloud or stay on premises? And is this more cost effective?
So I'll start. I think it really depends on which platform you're talking about. Core systems like your EMR and your PM are a lot harder to do in the cloud, depending on the size of your practice in a lot of cases. So we still have a hybrid environment where we're doing a lot of remote desktop or Citrix-based access. When I mention cloud-based, I think anything that's communication or that doesn't have to be on-prem, I think the more you can move that to the cloud makes sense. If there's peripheral applications that can be cloud-based and both allow you scalability and cost effectiveness, moving to the cloud in that case makes a lot of sense. But we still have our core systems on-prem with extension points that are secure and allow us to get to it in this situation. So,
Karen, go ahead.
I couldn't agree more with Matt. I mean, there's some applications that lend themselves to the cloud. Email is the one that comes to mind immediately. If Matt sends me an email and it arrives 5 minutes later than it should have, he doesn't know it, I don't know it, there's no impact. So that latency has no impact. If you have a 5-minute delay between clicks at the front desk when you're trying to check in patients, it's a catastrophe. So some applications really make sense to do in the cloud, others don't as of today. The other thing to think about is moving things out to the cloud helps spread your risk. If you're using G Suite for your email and you're using Kronos's hosted application for your time and attendance, and you're using Acumatica as your hosted accounting and ERP system, you're spreading your risk, which is really very helpful. But the core applications, the ones where you need to have complete control over speed and latency at every step that packet takes along the way, typically you're going to have better performance and better control on-prem. The other thing about being in a cloud provider is if Matt's practice management system has some sort of a problem, that is number one on Matt's priority list, and his team, that's what they're focused on, period. It's got to be up and running. If you're cloud hosted, if you're not the biggest customer, you're not number one on the list. And so I'd think very carefully about, your operational priorities, what's okay if it gets delayed or maybe isn't available for half a day, and what isn't. And the last thing I would say is the big change here is 6-7 years ago, the only people that used those systems intently were back office people. And honestly, if they were delayed for half an hour or something, it was a hassle, but it wasn't catastrophic. But now that so many of our clinical applications have moved to hosted platforms, there's just no tolerance for that kind of delay.
Very good. All right, so as a reminder, we've got about 10 minutes left. If there are any additional questions, please feel free to send them in. The next question I want to send around to the entire group. Ty, I'm going to start with you. Then we'll go to Matt and Karen, and then we'll roll it up with Mike. The question is, while we all expect to be back to normal very soon, there is talk about this kind of shutdown happening again. If it does, what technology would you get in place now to be better prepared next time? Ty, go for it.
Well, from a marketing perspective, it's all the same. It's all the same tools that we have. I would just suggest that a lot of the groups take their presence online beyond their website seriously. So the website's a powerful way to tell your story, but so many patients today are seeking care in alternative ways to just Googling and finding a website or going to a website that they've been to. So listings, I would say, is a very important thing. I've hit this already a couple times in this call, getting those links to your into your registration, your scheduling, your telemedicine, your COVID message, getting each of the doctors to have a presence online so that they're independently telling your story and attracting patients into your practice, no matter what happens in a normal course of business, are powerful tools. And sitting here listening to the conversation between the IT experts here, telling everybody on the call about all of the things that you have to worry about is daunting. I have to worry about those in my business, but I worry about them at a different level. So I want to just say one point that my team is actually giving away an offering to anybody on the call or anybody who needs help on their listings management during this COVID time. So you got 100,000 things on your list. If you want us to help you for no cost, we'll help you get your listings lined up, get all your links done correctly. If you just want to contact me, my team will take care of those pieces for you and help out any other way we can.
Very good. Thanks, Ty. Matt?
Yeah, so I would kind of just build on what we've talked about. So just, not throwing all the procedures and protocols that you've put in place during this COVID-19 situation and say, okay, great, we're done with that. We need to build on these. We need to make the solutions more elegant, get more integrations, more automation. A lot of the processes that we've put in place have to be manual because we don't have time to build interfaces for everything that we do. So we're going to continue to take away steps that are either manually done or left up to staff. We're going to refine our processes. I think the biggest thing that IBGI as a practice has learned during this is how important it is for our teams, our providers, their medical teams, as well as our leadership teams, to be able to communicate when you're all not in the same office. So I use this anecdote a lot, but a week before COVID, having 50 doctors on a conference call together was a very stressful thing for me. And now you can hear a pin drop. You know, everyone's gone forward a year or 2 years in terms of the sophistication of our teams. And so just maintaining that and encouraging that for your physicians and the leadership of your organization. So for us, I mean, it's just getting really good at, you know, Google Meetings and Zoom and these kind of things have been very beneficial, and we want to continue that.
Very good. Karen? Same question.
I would say that for those folks on the call, you know, this administration is considering making permanent some of the relaxed regulations around telemedicine. And so I would encourage you through whatever advocacy channel you have to encourage those changes to be made permanent. There are other changes I think would be beneficial to our organizations. Ty, thanks for saying something. You reminded me, Somerset, we have on our website a free do-it-yourself security assessment for remote workers. So if you do have people at home, you are a little worried, you can go download that free do-it-yourself assessment and run through it and kind of see where you are. But I would say building for the future, just what Matt said, taking this experience, what worked, great, let's build on that, let's institutionalize it, let's socialize it, let's harden it, and then figure out what didn't work and what we kind of need to change for the next time so it can go smoother.
Very good. Mike, anything you want to tag on?
Mike, you're muted.
Yeah, I'm sorry. I would say make telemedicine a permanent part of my practice, so it's not a transition when this occurs, and make sure that that's perfected, and therefore it's a seamless event if that occurs, and I put the patient first. I think next would be, we've talked a lot about the interesting aspect of having Zoom and team meetings with our physicians, but probably the importance of the, you know, sub-team meetings that need to occur with Zoom and team to make sure that our team is staying connected. They're talking about any billing or claims problems, whatever. So I think making sure that while they're working by themselves, they're regularly a part of group meetings, subgroup meetings, et cetera, so that you are staying connected, you are staying current. And it's way better than email to have communication like this so that they're hearing what's going on with the practice, what's going on with their little department. So I think of those two things. And then obviously everything you need to do to bill and collect. I mean, because at the end of the day, we're still going to be billing and collecting, and that has to function no matter what. So to me, that's the third item that I think of as a non-technology person. So.
Very good. I like it. Yeah, Matt, go ahead.
I was just going to add one thing to what Mike just said. You know, when we talk about Zoom or Teams or Google, a lot of it right now is video, and that's great when you can get everybody together. The other piece that those tools a lot of times offer, depending on your organization, is asynchronous communication, right? So again, if you can get away from email, we use Google Chat. You know, Microsoft Teams has a chat component. So to connect those teams, but allow them to be efficient, that's another piece I think organizations should really be looking at if they aren't already.
Very good. Ty, I want to circle back to you. I know you had a chance to go on this topic already, but you mentioned something earlier in the presentation that I think when we're talking about preparing for this to happen again, you mentioned being able to communicate with your patients. You know what I mean? Is there anything else you want to add to that? I think you have a platform for that. There are other platforms. I think that's a critical piece. Do you want to hammer that one home at all?
Yeah, I would say I was actually very surprised at how many of our customers actually did not have an easy way to get a message out to their patients. I was honestly, I just when we have those features in our platform so that a practice could say, hey, send a message to the last 2 years of our patients who've come through and inform them of telemedicine, inform them of these other things. And while I know we have a great feature set for that, I was actually kind of surprised that they didn't have at least an email way to communicate. And email is effective. So yeah, I mean, I have a great solution for it. I would say staying connected to patients and keeping them up to date has to be a core feature going forward, whether it's through a platform like mine or something else that you have in place. I would think that's something that needs to be on the list as key.
Very good. So we've got a couple of minutes left. Does anybody else have something that they would like to make sure that they're able to say to our audience before we end the call?
We're going to
All
get
right,
through it.
being none.
I would say
I'm sorry, Ty, go ahead.
we're going to get through it. It's going to be okay.
I love it. All right, well, fabulous. That's our time for today. Thank you to everyone who joined us here today, and special thanks to our panelists. Please note this was just the first of our webinar series, Emergency Survival Guide. We're going to be doing these each month. After this will be a short survey. Please tell us what you liked, what you didn't like, and what you'd like to hear next time. Before you depart, Mike McWilliams has a brief announcement. Mike?
Thanks, Lance. Great job. Karen, Mike, Ty, Matt, thank you very much for being on this. It was a great webinar, and you guys did fantastic. It's nice to, I always enjoy making sure that we have a great business as well as a technology forum and putting this all together. As Lance stated, well, some of you guys know and some of you guys don't know that we put on a healthcare technology summit every year. We don't know whether we're going to be able to do it this year. We're certainly hoping, but we don't know. And so we thought we would put together the emergency survival guide for the remaining of the month and kind of picking technology topics and business topics to basically help educate our the people that we want to work with, and that's you. And so, as Lance stated, we're going to be sending out a survey. And if you could just tell us what we did right, what we did wrong, we'd really like to get better at this. And also what you'd like to hear next. We're going to kind of, whoever has the most interest in whatever it may be, a platform like Ty's, whether it be cloud solutions, security solutions, whatever it may be, we're going to pick that for next month. And so I'm just saying, hey, please fill that out. An email will be sent to you, and we'll take it from there and make sure to, to go from there. But anyway, thank you again. Lance, again, great job. Again, Karen, Mike, Ty, Matt, couldn't have said, you guys did a fantastic job, and we appreciate the partnership that we have with each and every one of you and what you do for us and this community. I know the people on the call were probably very appreciative and so forth. I will leave it with this. If anybody has any questions, from an IT perspective, we're here. Just call, no cost. We'll be happy to answer and help out in any way we can. And if you'd like to have any of the emails from the panelists, just let me know, and I'll make sure and get that over to you guys. So with that said, thank you very much, and have a great rest of your day, and go electives for May. And let's turn it on and get going. Thank you.
I love it. Thanks, everybody. Bye now.
Thanks.